I'm happy to see a lot of men. I'm used to speaking to a lot of women, but I'm extremely happy seeing a lot of men folk here. And you'll go away? Thank you. To support me, I have Dr. Shubhankar with me as well here. And what we will do is, I have just chosen 3 cases of secondary amenorrhea, which we will, the endocrinologist and the gynecologist will see in liaison with, and we will discuss 3 cases up and down. They are absolutely paper-made cases, and yeah, we will. Krishna wants me to include a lot of audience in the discussion. We will allow a lot of audience interaction as well. Okay, so we have Dr. Shubhankar, Dr. Mala, Dr. Shanti and Dr. Sampath Kumari, who are quite eminent in their own fields of managing secondary amenorrhea. So, and we have to thank Dr. Krishna. This is the other side of Krishna, how he is inside Ramchandra Medical College, being always pampered by Gopier, and that's why the liaison between gynecologist and endocrinologist. Thanks, Dr. Krishna, for involving Oxy and, of course, me in this symposium. The panel outline, we will have case-based learning, 3 clinical vignettes, 8 to 10 questions on each, and 40 minutes, 45 minutes altogether. And short questions promised, brief answers expected, evidence projected at the end of each case if possible. Okay, but I think all of you will overall agree to say that any secondary amenorrhea, whether it is a gynecologist or an endocrinologist, you will rule out pregnancy and whispers to condom, boss, if you fail, we both will fail out of business. And so taking that into consideration, any secondary amenorrhea, whether she's 21 or 61, we will rule out pregnancy and then go ahead and see what can we do about it. So this case study, we will have a problem, a solution, and finally the results. Going to case 1. 20 years, Mrs. GY, married for just 1 year, history of amenorrhea for 3 months, comes to the gynec OPD with urine pregnancy test being negative, as we said, and she comes to you for consultation. Her past periods were 2 to 3 days, 25 to 45 days of interval, moderate, painless with no clots. She has a family history of diabetes mellitus, and she is on the overweight, though her BMI is 28.3, and she has a little bit of hirsutism, no galactoria. Her general physical examination otherwise looks normal, and her abdominal examination, speculum examination, per vaginal examination, nothing very major detectable. What would you want to do, Dr. Sampath Kumari? Can we have more mics?
Since her periods is almost regular, 25 to 45 days with a moderate and painless, with a UPT negative, we have to rule out the history of family, since the family history of diabetes also present, rule out diabetes, and then you have to go for thyroid profile to rule out any hyper or hypothyroidism present.
Okay.
And then you should, since hirsutism is present, we have to go for other investigations, such as FSH, LH and prolactin.
You will do that right away, or will you give her withdrawal first?
We will give the first withdrawal. Okay. Withdrawal will give, and we will see whether it is after the withdrawal bleeding is present or not. If the bleeding is not there, you can go for other investigations. If withdrawal is present, means as you told, there's no need for FSH LH level evaluation.
Okay, Dr. Shubhankar, you want to differ from her, or you will go the same way?
No, by and large, the approach would be the same. With 3 months amenorrhea with hirsutism, obese, positive family history, the possibility of polycystic ovarian disease looms large, but there could be other issues like hyperprolactinemia as well, and as also thyroid dysfunction, which needs to be excluded. But a real practical point, as she has already pointed out, is doing a progesterone withdrawal. If you have a positive, if that's positive, then possibly you don't need to bother about hyperprolactinemia as a cause for her amenorrhea. Yeah, so I by and large
agree with her, and you will give a progesterone challenge.
Yes.
Okay.
Yes.
Fine. I hope the other 2 panelists also would agree, and we will give her a progesterone challenge first. And she had gone to a local doctor, and this was the ultrasound picture which was done. Ultrasound, transvaginal ultrasonography said uterus 8.5 by 7.5 by 5.3, endometrium around 8 millimeters, and both ovaries show multiple small follicles suggestive of PCOD. This is the scan report with which she has come to, because she's not had a period and she was longing for pregnancy, so she went went to and see whether the UPT was not positive. So she said at least a scan could pick up, and so she went to a local doctor to see the ultrasound picture as this one. So what would be your comment on this, Dr. Shanti Gunasingh?
Can I
Sure.
before
Sure.
she responds? I mean, that's for me to learn from my obstetrician colleagues. If the uterine pregnancy test is negative, do you still expect the ultrasound will pick up a pregnancy?
No, it will not. That's exactly the point we're just trying to hit at. So when the UPT is negative, and of course when the what we would embark is a serum beta HCG and not the ultrasound, because for the ultrasound to pick up your serum beta HCG has to be somewhere around 2,500, 3,000. Otherwise, even a good resolution TVS probe will not pick up pregnancy. Right? So we go on that, and we have a basic idea that this patient probably is a PCOD, and then we go on to. And now, as we all agreed, we would give her withdrawal with progesterone. And now she did withdraw, and then now what do you want to do? And she said that I'm quite keen on having pregnancy and things like that. Now she has had her withdrawal. Dr. Mala, how do you want to take her from there? You have given her progesterone, and she has had withdrawal periods, and she comes to you as soon as she bled.
Supposing she does, this is very important at this point to understand if pregnancy is required or pregnancy is not required. Because for me, that would mean two very different ways of management.
Fantastic. So you will think in terms of putting her on a contraceptive pill or something like that, but if she is keen on pregnancy, you will not.
Absolutely.
Fine. So at that point of time, she's only 20 years old, and she is keen on pregnancy, but not at the moment. She's come to you for her irregular periods and a BMI of 27 point something and a history of diabetes, and she's not very keen on embarking a pregnancy at the moment. So now
So
what do you
if
want
she
to do?
says, no, I don't want pregnancy
Now.
For the present,
Yeah.
then possibly I would still investigate her a little more.
What all would you
I
do?
would want a testosterone levels.
Okay.
I would want a 17 OHP level,
Okay.
that's 17 hydroxyprogesterone, and I would want a prolactin level.
Prolactin level.
Because
Why would you want that?
prolactin causes hirsutism. It can also cause polycystic ovarian response.
Fine.
In the
And why would you
scan.
want a 17 hydroxyprogesterone?
Because a late onset CAH can happen, and
Okay.
that would sort of reflect to know the
You
diagnosis.
don't want to do a testosterone because she's got hirsutism.
No, I would want to do a
You
testosterone.
would want to do a testosterone as well, free testosterone.
Because doing an FSH-LH does not give me any added information, and it is not a part of criteria for me to know whether it is a polycystic ovary. So today, from the endocrinology perspective, we actually don't do an FSH-LH
Okay.
unless you are looking at fertility.
Okay.
Then possibly that would become important.
No,
at
she
that
doesn't
point.
want pregnancy at the moment, but she's only 20 years old. She's quite keen to have
In which
pregnancy
case,
later on.
having one FSH-LH may not make too much of a
Okay,
difference.
fine. It's only the cost. Dr. Shanti and Dr. Sampath Kumar, would you want to differ and say, we will do a FSH-LH?
No, this patient, I would do a GTT also and one TSH.
Fine.
So
Okay.
that GTT is very important for this
Okay,
patient.
fine.
Yeah. And then I think for a polycystic ovarian disease and with family history, FSH and LH, if you're embarking on fertility, probably it's good.
No, this lady is not keen on now, but she's only 20 years and she's quite keen
But
to
then
have
also I
pregnancy.
think, see, all these people, it will be better to have a baseline FSH. That's what
Okay.
I think, especially for fertility purpose. Although she is not interested right now. Suppose we see so many patients now with high FSH, 12, 15, even although they are quite young. So in that even probably we can counsel them
And go
regarding
ahead and do
that.
an FSH-LH.
I think
Okay.
I have a
Yeah, sure, sir.
I think FSH-LH is required if I am asked to do, because if you go for a criteria for a diagnosed PCOS, it is a clinical diagnosis, excludes secondary causes.
Perfect.
Premature ovarian failure is one of the common thing. It can come right from menarche till well before menopause.
Yes.
So I don't hesitate to
Do an FSH-LH in addition to the investigations which they have.
And after withdrawal
Progesterone.
period,
She had a
She had a
withdrawal.
withdrawal with
After withdrawal,
progesterone.
Withdrawal
With
progesterone tells just
Progesterone
estrogen adequacy. It doesn't rule out the thing. You can have a 2 years period.
Usually premenopausal is usually the FSH is the first one that is affected.
Yeah.
It's so you will not get, that is how we differentiate that the progesterone is less
Yes.
by giving a withdrawal. So if the withdrawal has happened, very unlikely to be
No, the reason being, the withdrawal bleeding concept came because we used to get FSH-LH after 6 weeks or 8 weeks, olden days with RIA. That's why they told us E is adequate only to see that
P is there.
P is there.
Okay.
But now with era where we can get overnight your test to know adequacy of E and P, I don't think there will be any hesitation in asking FSH levels.
Fine, okay. So now the issue is whether we'll do FSH LH, and I think as gynecologists we would definitely do an FSH and LH to have the criteria of PCO, because I think that diagnosis is a doubt now whether it's PCO or something else. So we will say that we will do FSH and LH definitely, and that is the first set of investigations, Dr. Ramesh.
1 minute in this, I want to ask Dr. Mala. One of the patient, she is around 22 years only, married similar cases. But from the period of menarche, she is telling that she was having an irregular periods. After that marriage, she is afraid of her mother-in-law. Without withdrawal bleeding, she is telling that she had withdrawal bleeding.
Yep.
But if we verify, if we ask the patient that there is no bleeding, for every time if we give progesterone, she is telling withdrawal bleeding is present. How to proceed with that patient?
If you feel that there is these kind of problems and there is an anticipation that there may be some fallacy in the history, then definitely you have to do. But that was not what I took into the picture.
Okay, but I think as to fit into the criteria of PCOS, we would definitely love to have FSH and LH.
But where is the criteria? What does FSH LH values mean? There is no criteria.
There's no criteria
Whether you
putting
take
into FSH
the
and
Rotterdam criteria
Yes.
or the previous WHO criteria.
Yes, definitely. It's
there
only
is no
clinical
FSH
and
LH.
agreed.
But if you want to do, no, now it's all about cost.
Cost, yeah.
So if you want to do the entire thing,
Panel,
then
then
you
it's a
do the
different
LH
story.
FSH 2:1 ratio, all that blah blah, which we used to do much earlier. But right now, is it required? Once you have a diagnosis of, you feel that the person is having PCO, she's just come into your clinic, I wouldn't do. If I suspected premature ovarian failure, possibly yes.
Okay.
But like let's say this particular lady, before I did a withdrawal,
You're
supposing she never had a problem. Usually we think that in PCO, the problems usually start from menarche itself.
Okay.
But this girl was perfectly all right, 20 years, first time, I would definitely think of premature ovarian failure.
Okay.
But supposing she did not have, she had irregular periods on and off from pubarche or menarche, then I would definitely think that maybe it is just a PCO.
But I think, madam, in our practice, nowadays young girls who just within 1 year they become anxious and they come. Many of them we are seeing FSH in the borderline. So I think in that event we tell them you have to come regularly for treatment and try to...
So even if she's not keen on a pregnancy now, we will say think in terms of pregnancy as soon as possible. So then you may probably want an FSH. Yeah, fine. So you're not wrong in saying that. And her glucose tolerance test. Yes, sir.
Yeah, just to interrupt. I mean, to interpret the FSH, I mean, this day 2, it's been mentioned. So unless we know the day when the FSH was done, you may have FSH on the higher side if you're collecting an FSH.
We do it only on day 2 or day 3.
Day 2 or day 3, follicular phase.
Yeah.
No, we are very clear about that, and so we are quite happy to have only a day 2 or a day 3 in the follicular phase. Yes, sir.
You told about the free testosterone. See, we are used to total testosterone, and only when we have some ambiguity in that,
then you do a
free testosterone. So I think that should be made clear.
Sure.
And that's because the total testosterone assay is more robust.
Okay. So her GTT done 100 grams, fasting 1, 2, 3. Phenomenally high. I'm sure there's no doubt. Let's not impact on it.
Again, my small comment, maybe we would take recourse to just a 2-hour value and after 75 grams glucose. I mean, that's
what always you'll say, sir. But then so many times we see 1 hour level being a bit high.
Yeah.
That is 2 hours is quite normal.
Yeah.
But then 1 hour, then probably an IGT, it will help us to
say whether she is,
better, I think.
And I think the 2-hour value, let's not go into that controversy. We go into that, we will not end up, because that's probably in pregnancy, definitely we will go into 75 grams, 0 and 2. But a patient with PCO, we will definitely stick to 0, 1 and 2. 3 you would not.
Why did you use 100 grams?
Yeah, 100 grams is not warranted.
No, 100 grams is not warranted. She came with a set of investigations done. There are enough number of labs who do 75, enough number of labs who do 100, and they do 0, 1. There are few labs who do 0, half an hour, 1 hour, 1.5 hours and 2 hours. Also,
Dr. Palniappan, I would ask you, will you ask her to redo the test?
This GTT, I will not. I will not ask her to redo the test. Okay, so her free testosterone prolactin, we did say that we would do, and we'll assume that to be normal at the moment. And free T4 TSH was also done, and it is normal. And so now what do we do? Do we do a fasting insulin or not? Dr. Mala did answer that question in the previous previous lecture, saying that we wouldn't do a fasting insulin to fasting glucose value. Dr. Mala, would you want to reiterate that fact again, or what would you want to say about
fasting insulin
in this particular case?
In most of our population is going to be high. So what happens is it leads to unnecessary treatment, thinking that we should reduce insulin. It also leads to a lot of panic in patients' mind. Oh, my insulin is so high, 200, 300, they come with reports like that. And I also see stimulated insulin being 800, 900. So I think that we should not do, because anyway 70 to 80% of our population is insulin resistant, and we are going to get high insulin levels. However, if you are doing a research protocol where you want to know the insulin resistance, then possibly it's okay, but otherwise not routinely.
Okay. So you wouldn't do a fasting insulin level, and why not levels? Because fasting insulin levels are not very reliable. 25% of normal patients have insulin values that overlap with those of insulin resistance, and we did have a cutoff of 4.5 some time back, and we're not using it anymore on a ratio of less than 7, but we're not using that at the moment. So fasting insulin we will not do at the moment for clinical practices. So should a repeat ultrasound be done is the question. We had a report in the previous slide. So you did ask me whether I would do a repeat GTT, but what is your thought on, would you repeat the ultrasound?
You're asking?
Yes, you or, you can give it to Dr. Shanti.
Okay. I don't think there is any need to repeat the ultrasound again.
Okay, Dr. Sampath, would you want to do the repeat the ultrasound? Okay. Coming to the endocrinologist after Dr. Sampath. You also don't want to repeat the ultrasound. Okay. You both, would you want to repeat the ultrasound? Okay, now.
You don't even want the first one.
Oh, you don't even want the first one. Okay, that is being unfair. I would definitely want a repeat ultrasound, because the previous ultrasound did not tell anything about the...
Most of the adolescent girls nowadays, they come with the scan report of PCO.
PCO, that's perfect.
Anything.
That's exactly what I want. And let me say that there are not many radiologists inside the hall, so I can say that very boldly. And there is a beautiful article which says PCO is the most abused diagnosis on an ultrasound, right? So we need to take that ultrasound report with a pinch of salt, and I would definitely repeat an ultrasound in the place wherever. I'm not recommending this particular place, but then I think you'll have to have a very clear ultrasound picture which was done, and uterus had the same dimensions. Of course, nobody can go wrong in dimensions other than the intraabsorber error, and the ovaries did say the values, and did say that there were multiple follicles, 10 to 12, more than 12 arranged in the periphery with thick stroma, was something which I was just looking at, and that would fit into the criteria, says, and that is why we want a repeat ultrasound very pakka, because if you see the Rotterdam criteria, ultrasound evidence of PCO was very clear. We can't take that picture. There were no pictures in the previous ultrasound, so I think we need to be very sure that we have ultrasound evidence. Yes.
If we have two criteria, that's enough.
Correct.
And she has been having once in 45 days.
Correct. I know.
And that along with hirsutism,
correct,
which is clinical evidence
correct,
of...
absolutely.
And one PCO, I think I will not.
Correct. Okay, but then are you going to have anything wrong in doing a non-invasive process? It's just the cost again. Is that what you're going to say? Okay, fine. It's fine. So, yeah.
Dr. Palyanikpan, let's assume the next ultrasound didn't show multiple follicles, whatever.
Yeah.
So, does our approach and diagnosis change?
It won't change, but you're very sure that you're dealing with the PCO only, is the only criteria, because you already have two criteria, I agree, but in a case if you don't have...
that's what I'm saying. So if the next ultrasound did not show polycystic ovarian...
Still we will go ahead and take it as PCO.
Yeah. So
I agree with you.
Then why you want to repeat that ultrasound? Anyway, if other ultrasound is not going to be a PCO...
In a classical case like this, you have the features. At times you may not have, and still it may be a PCO and you will miss it. That's exactly the point I'm telling, because the ultrasound report is the most abused report is PCO. That's exactly the point which I'm trying to stress across.
Palyanikpan, can I set the cat among the pigeons?
Sorry?
Let's say you had this ultrasound that show PCOS. What tells you that the PCOS is the underlying pathology? It doesn't. Having a morphologic PCOS, even with Rotterdam criteria, a diagnosis of PCOS by ultrasound doesn't tell you that the underlying pathology in this patient is PCOS.
Correct. I agree with the fact.
So that's $600 down the drain.
Okay, fine. Okay.
Sir, can I add another comment? There are women who become defensive when they say, when we tell them the diagnosis is PCOS. They go shopping around for a radiologist who will give them a normal study scan.
Perfect.
And then it's like a cancer diagnosis.
Perfect.
We end up arguing. And
I mean, that's the only point which I'm just trying to drive across the audience. We need to take that report with a pinch of salt and just not say it's a PCO. I agree there are other features of PCO in this particular patient. Agreed. As Dr. Shubhankar said, the management is not going to change, but the report we have to be very, very cautious in interpreting it. Fine. So the criteria, I'm sure all of you would understand ASRM and Escherick Rotterdam criteria. And what do you think is the deficiency of this Rotterdam criteria, Dr. Shanti? What would you want to say that there is some deficiency? The Rotterdam criteria did have deficiencies, and we did meet again in Thessaloniki, and then it went on and on. And so what do you think is the deficiency of this diagnostic criteria of Rotterdam 2003?
I mean, had more stress on the ultrasound criteria, which can be subjective
Abused.
actually. So that is one thing. And
Madam, you were guiding, Dr. Mala, you wanted to tell something about Rotterdam initially. Would you want to say
actually,
that for practice?
For us, from the endocrinologic perspective, there's the dilemmas or the controversies start right from the naming.
Okay.
The importance that is there is no mention of insulin resistance and things like that.
So insulin resistance was not included at all, isn't it?
So those are the reasons why we feel that possibly all that also has to go into the criteria.
So that is not included at all. That's exactly the biggest deficiency of Rotterdam criteria, was that the hyperinsulinemia was not included at all. And we also need to have, there were alternative criteria which did not come through as guidelines, but then there are enough criteria which were followed, and this is the Sultan criteria, which did have a big discussion on the Thessaloniki consensus, which said oligo or amenorrhea 2 years after menarche, clinical hyperandrogenism, biological hyperandrogenism, insulin resistance or hyperinsulinemia, whatever may be, we'll see how we diagnose each one of them. And of course, polycystic ovaries on ultrasound was the criteria which was put forth in 2006 and then passed through the Thessaloniki in 2009-10. And so, but this did not translate into guidelines and said we have to follow this criteria. So there has been enough complications, controversies about coming to a very clear diagnosis of PCOS, though our management options may not change much, and we will go ahead and manage this particular patient as a PCO. And so, yeah.
With our experience, whatever criteria, whatever guidelines you have, investigations or scan and blood investigation, when the patient comes walking to our clinic, to her OP, with their appearance and history itself, we can tell she is having PCOS. It doesn't mean that we want ultrasound report, investigation.
No, correct. But then I think we need to also have some amount of evidence to say that. Yeah,
but,
no, I agree. Your gut feeling is that she's a PCO, but I think we need to.
Most of the patients with the adolescents, they come with obese. They don't do any work. So with that, we can, with the way itself, we can.
I think I totally agree. PCOS is a clinical diagnosis. If you carefully take the history and you can minimize the investigation, and whatever tests you are doing, n number of tests is only for exclude.
Correct.
That's why probably it requires lot of investigation to exclude other conditions rather than to conclude PCOS.
I totally agree with you, but the question is, would you not investigate a lady just only from history because she's got a little bit of obesity and a little bit of hair here and there? Would you consider that particular girl as PCO and start treatment without having undergone a panel of investigations, is my question.
No, that's I know. At first time when you are seeing, probably you will investigate more. If you have got somebody perimenarcheal history 10 years down the line you are seeing, I think your number of investigations comes down.
Can come down. So you can individualize your investigations. Fine.
Such a patients coming to Gosha Hospital and IOG, we cannot do such an investigation.
I agree with you. There are limitations. Cost is a limitation. I am not telling no, but I think in an academic forum we need to have say, we will do this, we will not do that. I agree.
But whatever it is a diagnosis of exclusion. So I think we have to do all these investigations. So we might come to a provisional diagnosis and we will be correct about that. But it is mandatory that we should not miss even that one case of late onset CAH. That is very important.
Agreed. Okay. So can we predict polycystic ovarian syndrome? Very controversial subject too. Then we'll move on to treatment. Dr. Shubhankar, would you want to take that question and say, can we predict PCO?
I didn't understand. I mean, predict
that this particular girl is going to have PCO in life.
Okay. Yes, I mean the phenotype, obesity, and all early adrenarche, all these could suggest, but we can't say for certain that
Dr. Mala is waiting to grab the mic. Yeah.
Family history very important.
Of family history of PCO.
PCO or male pattern balding in the father.
Okay.
This is also a forerunner of PCO in a girl.
Okay.
So history, birth history, premature deliveries, small for
gestational age baby.
Yeah.
Okay.
And then of course like
not a macrosomic baby.
Not a male. Yeah. Macrosomic.
Both a very small or a very big baby. Okay, fine. And what I could search in the
anti-epileptic drugs also nowadays. Many of these girls are on anti-epileptic drugs.
Anti-epileptic
and
drugs.
Always we see that they develop.
Okay, fine. So this is something which I just pulled out an interesting article just to say adiopentin is a very significant marker, lower in the daughters of women who have PCOS, and so detected before the onset of hyperandrogenism, hyponectin, and early marker of metabolic derangement in adolescent girls. That's just a deviation from now. What is the reliable test for insulin resistance, Dr. Mala? I want you to take this question and answer us, because you did have a big lecture on that, and so we could get points in that. So what do you think is the most reliable test for insulin resistance?
I think the most reliable thing that you should do for insulin resistance is look at this girl very carefully, look for clinical markers of insulin resistance like acanthosis nigricans.
Okay.
So those would be better markers than to do an insulin glucose ratio.
Okay.
And possibly look at her BMI, look at her waist hip ratio or a waist circumference, and save her that cost of doing that insulin glucose ratio.
Okay. But for, would you want to comment on these two, the euglycemic clamp technique and the intravenous glucose tolerance test? And that is supposed to have been said in textbooks as the most reliable test for it. None of us, I have not done, I don't know how to do that test.
Yeah, I have done.
Okay.
So
that's exactly the reason why I am asking you.
It is not an easy test to do, and it is not required.
Fine.
This euglycemic clamp technique is what otherwise we call HOMA, IR, and we look at insulin resistance. This is frequently sampled intravenous GTT is another way of looking at insulin resistance. They are very good methods. There is no doubt about it at all, but only as a research tool.
We will not do it in clinical practice. Yes, sir.
In fact, I have undergone that test as a part of our research protocol. We were the first subjects.
Okay.
Most difficult. Even if you just wince, your insulin levels and adrenal levels fluctuate. I think even insulin level we are not asking. I don't think we have to ask for a euglycemic clamp technique.
Fine. Thank you very much for that feedback. And both need hospitalization are not practical, and it is not done in clinical scenario. And as she said, acanthosis nigricans, obesity and menstrual irregularity are very good signs of insulin resistance in the adolescents, and not, you need not have written test to say that she is having insulin resistance, right? So we will look for clinical markers of insulin resistance. And I'm sure all of you would understand that we have more of mouse wives than housewives. Now, and obesity is an impinging problem, and now how would you treat this particular patient?
Before that, excuse me, one small question.
Yes, sure.
You have discussed so many etiological causes for the PCOD. Now, the stress, depression, can it induce PCOS? Because we know that fear of pregnancy can postpone the menstrual cycle or rather amenorrhea. So what is the role of the stress, depression or mental conditions? Are we not supposed to rule out these conditions when we are studying a case of PCOS?
This is a 20-year-old girl who's just not gone through.
Naturally, she can have.
She can. I'm not telling you. Now she's stressed for the last 6 months, 8 months, whatever. I perfectly agree with you. I'm not probably the right person to say that 6 months of stress has induced PCOS in her. I don't know. Would the panelists want to take that question?
Because steroids levels, when it goes up, it is going to spoil the cycles.
Yes, I agree with you, sir. We move across? Okay. So how would you want to treat this particular patient?
Just to answer your question, this is very well established that periods of stress causes abnormal period cycles, menstrual irregularities, scanty cycles, especially athletes, people staying away from home, hostels. But what the problem happens is at the pituitary level. So it's not so much as polycystic ovarian response, it is a pituitary level of FSH-LH decreasing.
So there is no change in disparity of FSH-LH ratio. Only FSH-LH ratio is changing.
Both are low.
Both are reduced.
But if you have this amenorrhea for long enough, you could well have ultrasound changes in the ovaries of polycystic like changes, which is not the same as PCOD.
True, and I agree with his point that a lot of times what happens is you see 12 standard girls who come for almost a year with no periods, and this is and stress is a very, very important part of this whole thing. But unlike it, you are not going to have PCOS features. You're really going to have even some people may have a slight degree of breast atrophy. It's mostly hypothalamic amenorrhea that you end up seeing rather than PCOS-like features. If you're having PCOS-like features, it's mostly the tuition syndrome in Tamil Nadu, where, you know, everybody starts in the morning with 2 hours of tuition, they go to work, then they come back and they do another 6 hours of tuition, then eat outside. So that's a different kind, that is PCOS, but the stress of 12th standard induces amenorrhea in a lot of girls, and I think that's something you need to look at.
Fine. Okay. So now
Excuse me, just to add up, see this adolescent girls, the problem is unlike the young adults. There, the stress and depression is a common comorbidity. They come and cry that they can't socialize. They don't socialize the dress size, look. So this is, see, and the depression is very common. I don't know stress.
Perfect.
So what it requires is some sort of some understanding. So you tell them that, see, look, you cut down the diet and things will be all right. It requires a lot of, but it's very difficult. You can't send them to the psychiatrist.
Correct.
Okay.
We can't.
So, but I don't know how useful is SSRI, but depression is a common comorbidity starting from, what are that? Adolescent, then young adult, later on as well. Obesity and depression is a very, like diabetes, we talk about diabetes and hypertension, diabetes, obesity and depression is a very, they coexist together, and this has to be addressed. We rarely bring a psychiatrist or psychologist, maybe sometimes.
How would you want to manage this particular patient? Slides, please. Yeah. What did you want to do with this particular patient? How would you want to treat her?
Well, that will partly depend on what is her current concern, major concern. Is it the...
She's not very keen on having a pregnancy at
so
the moment.
hirsutism, and the periods, the irregular periods. The first thing, of course, would be to explain about lifestyle, explain about importance of weight loss, regular exercise. Those would be the first points to stress upon.
So weight loss, probably her BMI being 27 point something. Dr. Mala, anything else would you want to say?
Yes, every time she, in the beginning, I would definitely say what Dr. Subhankar is saying, that lifestyle and bring her BMI. With that itself, the menstrual irregularities may come back to normal.
Perfect.
Just by her diet and exercise. But if it does not, till it does, she should be given withdrawal every 45 days if she is not pregnant, and she should have a cycle.
So you're happy only with progesterone from the, probably see for a period, if not give medroxyprogesterone, whatever progesterone for 10 days and then give her withdrawal once in 40 days.
Yes.
Fine. So Madam Shanti, you're happy with it, or would you want to put her on OCP or?
See, this withdrawal bleed, we can give MPA, but for this patient, she's likely to, she would embark on pregnancy shortly, not right now probably. Yes. So I thought, although her testosterone is normal, we can put her on combined OCPs for 3 cycles or 6 cycles. So that will actually, suppose if there is any mild elevation, now they say even more than 2, the normal level they say up to 7. But then even more than 2 is has some impact, they say. So all that, so probably if she has a COCP which contains both
estrogen and progesterone.
Okay, I think it will be
any specific estrogen progesterone would you want to put? Any specific progesterone on the OCP, or you're happy with any local brand of contraceptive pill?
No, of course we can use both. Drosperinone can be used. Then so that will also decrease her weight. At least it will be weight neutral, and that will motivate her more with all the lifestyle modification. Probably that might help.
Okay, so you would do weight loss, lifestyle modification, and depending on her levels of hair and the Galloway scoring, you would think in terms of hair removal anti-androgens, and you would put her either on a progestogen or a combined OCP, especially a drosperinone based OCP. Dr. Sampath Kumari, would you want to start her on a cyproterone based OCP, or are you happy with the drosperinone based OCP?
With this patient, I'll ask her, as Madam told, only the diet and exercise to reduce the weight, and after that I'll ask her to become pregnant.
Fine, no, perfectly fine, yeah. We will have to tell her that she has to become as pregnant as fast as possible, there's no doubt, yeah.
There were some concerns regarding the drospirenone-based OCPs because they produced a lot of venous thromboembolisms, so especially the vena cava, yeah. So that's why we have stopped writing nowadays the drospirenone-based OCPs.
What is given in our book, sir, that is drospirenone, actually it is combined usually with the third generation, that is the desogestrel. So, desogestrel, it is extensively used where, we were not using certain OCPs earlier because of thromboembolism, all those things. But desogestrel was considered to be relatively safe and they were using, hence that's what they say, probably an apparent increase.
Desogestrel, gestodine, and one more. These are good progesterones, fine, because they don't have. But then drospirenone in particular was found to have adverse things, and actually that's the reason we have stopped writing.
No, there is enough evidence to say that we did have evidence to say drospirenone, the pill scare of 1995 and things like that, the VTE, and then slowly what happened?
This is the recent evidence. The FDA has, I think, withdrawn it.
Sorry?
The FDA has withdrawn those drugs.
You mean to say? Is there a black box?
This is around 2 years back. It came back. So drospirenone, sir, any comments?
I think Ganapati is absolutely on the dot because there were two published articles that have shown VTEs with drospirenone. This is one, and the major one was in the NEJM a few years ago. And if I remember right, there was first a recommendation with the FDA advisory board for a black box warning. And most of us have stopped using any drospirenone-based thing. It takes a little while to trickle down, but be careful.
Fine. Okay. So then, if it's going to be drospirenone, would you be happy using cyproterone-based OCP because she's got anti-androgenic potentials in that?
Yes.
Okay, fine. So we will do weight loss, first line treatment in obese PCOS, at least loss of 5-10% decrease the testosterone and does improve the reproductive outcome, which is not what we're looking at, but it brings back the menses. And lifestyle modification, definitely yes, and cyproterone based OCP, yes. And so probably here we will not think in terms of drospirenone based OCP, we will probably as gynecologists think in terms of using a cyproterone based OCP because this patient has hirsutism, it will reduce density, diameter and growth, onset of action in acne and serum protection as well. And anti-androgens, let's not. Yes, sir, sure.
Comment on the cyproterone-based OCPs?
Yeah, sure.
Possibly there isn't enough evidence that there is a whole lot of difference in terms of clinical effects on hirsutism in between the different OCPs, and cyproterone's anti-androgenic action possibly is at much higher doses than what's used in a cyproterone-based OCP. And there it's suggested possibly the benefit is more from the estrogen component than from the cyproterone component. So I don't think we should be sort of belied into believing that if you're using a cyproterone-based OCP regimen, that's much better than any other form. I mean, that's my personal.
So you wouldn't say cyproterone-based OCP is better than any desogestrel or whatever?
Yeah.
Okay.
Can I ask?
Sorry. OCP in her mainly will be for an OCP.
You mean for contraception?
Yes,
okay.
Because she's 20 years
She's 20,
married.
she doesn't want a child at the moment.
For contraception, we have to give before we give her other modalities of treatment. For whether it is for the
But will it do any good or will it do harm is the question this particular patient. I'm sure it's going to do good for her PCO as well, right? Yeah,
I have a question to Shubhankar, Mala and everybody else. What about liraglutide in PCOS? Liraglutide?
Liraglutide.
Yeah.
For weight loss.
For weight loss, there are data now that's emerged that not only does weight loss.
There is some data on liraglutide in PCO patients as well as liraglutide in obese patients. And I think it has been it is approved recently also. But I don't have any patients on liraglutide.
Clinical experience very less. Only theoretic. I mean.
You have.
Okay, so now I'm sure all of you will be waiting to see whether we start metformin in this particular patient or not. So, insulin sensitizing agents, so what would you want to start? Would you start insulin sensitizing agent in this particular patient or not at all?
I would definitely start insulin sensitizing agents, considering what we saw in her GTT.
Yes.
So, that would definitely be started, and it would be only metformin. And because
why wouldn't you start any
pioglitazone,
yeah.
there is data in PCO that it is beneficial, but here it's going to add on to the weight. So I'm not comfortable using pioglitazone, and that too with all the data of pioglitazone causing bone weakness and things like that.
Perfect.
So I would put her on metformin. I might use. Oh, liver failure is not a concern.
Okay. So, but then you wouldn't use it on an adolescent girl like this?
No, I would not.
20, she's 20 years.
In any women, you have to be very careful,
careful.
when you use glitazone, and definitely not in a young woman.
Young women.
Metformin is safe, can be given, and yeah.
Okay, Dr. Sampath Kumar, would you agree with her that you will start metformin?
Low dose metformin
Low dose means what is the dose you would want to give?
with 500.
500 3 times a day. Okay, fine. So I'm sure you could go till 2 grams per day, and when combined with diet, significant weight loss is observed, reduces weight. We have a lot of evidence on that. Let's not go into details about that. And coming to surgical therapy, I don't think anybody would embark on and. Yeah, we were just coming into myoinositol, N-acetylcysteine, etc. We are just coming into it. Okay, so we wouldn't do any surgical therapy and bariatric surgery, individualized patients, so there is no dictum to use, and the LOD is done only as the very, very last resort, especially when you're embarking on a pregnancy and womb retrieval, etc. Otherwise, we wouldn't do. Now, what would you want to do as far as myoinositol and N-acetylcysteine is concerned in this particular patient? What is your recommendation? Would you add myoinositol and N-acetylcysteine, which are adjuncts in treatment of?
I would not, and
Dr. Mala would.
That's fine. Yeah.
No, you wouldn't. Okay, fine. Okay.
There is not enough evidence-based data.
Dr. Shanti?
Not much of evidence, but then there are a lot of papers which, and it's just a nutritional supplement. I think I would see when, especially when we are managing fertility, I mean, when fertility is the issue.
If this lady wants to conceive.
It does not cause any harm, when there are so many studies which say this is just a nutritional supplement and which is already present in the body.
Fine. Okay.
I think I will use myoinositol.
Dr. Sampath Kumar, would you want to use myoinositol?
I will also use it. The patient will be
Fine.
satisfied. At
So
least some tablet is
at least when this lady wants to say that I'm trying to become pregnant, maybe a couple of years later on, when that would definitely have yield in the ovarian potential, yes, as Dr. Rekha was telling. So I'm sure we would add, and there was enough evidence discussed in the recent cutting edge conference in Bangalore, and we had we could hear it from the horse's mouth, and we will think in terms of using myoinositol and N-acetylcysteine when she is thinking in terms of pregnancy, if not now. Okay. Yeah.
I'll just put in,
Sure.
I just wish to put on record that I do not agree to this, but of course I fully respect the opinion of our obstetrician colleagues.
Okay, I'm very happy that the panel is not agreeing with each other. Yes, sir.
Yeah, the question is, who is the ideal person to treat PCOD?
No, there's nobody. I don't think we'll embark into that.
I tell my young patients, look, I'm only a diabetologist.
Patient should decide.
I suggest that you go to a female endocrinologist with the hope that they follow evidence-based medicine. This myoinositol, they don't give.
There's no gender bias here. Why a female endocrinologist?
Who is the ideal person?
There's nothing called ideal.
Relatively, at least. That is why you and me are talking. If there is no, there are at least, there is one Mala Dharmalingam is a son of the soil, which is a Madras endocrinologist, and Calcutta men. What do you think? What will you do? Suppose your family member is a PCOD, what will you do then?
I think I also would like to place on record, as obstetricians and as society, we still do not have any proof of myoinositol. As individuals, certain people may be using, but we do not have evidence as yet. There are few papers, but that is not evidence enough.
That is the problem here.
I agree with you.
People
We don't have guidelines.
Pharmacology, pharmacy, you prescribe everything.
Yes,
No,
we
it's
don't
not
have
like
evidence.
that.
We don't have
It's
guidelines.
not like that, sir.
Then what is the purpose? You want to waste the money for myoinositol, or you get
Not
funny
like that, sir. No, I told you, sir. It is, that is
But this is happening. This is happening in the gynecologist room. Okay.
No, sir, initially itself I told you,
Look, I got nothing
guidelines
against
does
you. I got
not
nothing
come,
against you because
but so
I
many,
have-
see, metformin also it was like that. Endocrinologists were not using initially for pregnant women. But then now, obstetricians were the person who was using it extensively. Now they also agree that for decreasing the fetal loss, that is very important. So many things might change like that. I told you initially it's not a guideline, but then since it does not cause any other problem, as evidenced by so many studies, and a nutritious supplement, probably I would use. That's what I clearly told.
Please, we have to move on. It has to be. It has to be individualized, and she as an expert, of course, with in a given individual, she may use.
Sir, we agree a point. There is no evidence to say that you have to start myo-inositol and it does help. There is no evidence to say that, right? Okay, fine.
Most of the drugs are all prescribed are not evidence-based only in many situations.
Yes.
So if patient is coming, if you are not going to give any tablet, just to give the vitamin means
fine. So I think we are running in short of time. We will go to the next case. If we have time, we'll take that at the end. Mrs. O, 32 years old, para 2, live 2, last childbirth 15 years back, sterilized lady, presents with irregular menstrual cycles once in 2 to 3 months now for the last year or so, and it's erratic. She also has urinary urgency and frequency, and diabetes was ruled out. Her last menstrual period was 92 days back, and she has been on psychological support and anxiolytics for the last 6 months with a psychiatrist and has impaired sexual satisfaction, and she fights with her husband very often. Right, so now would you want to, Dr. Mala and Dr. Sampath Kumari, would you want to make a diagnosis on the history and examination history itself? I'll just put the slide on examination. General physical examination, normal, abdomen normal, speculum examination says loss of vaginal rugosity, dryness plus, and no incontinence, and PV is nothing very significant. So would you want to make a history on?
Galactorrhea as well?
No galactorrhea, no galactorrhea.
So your history is very, very specific to say that this lady of 32 years has reduced estrogen levels.
Yeah.
So
okay.
everything is pointing towards low estrogen.
Okay.
So I would want in this particular lady FSH, LH and a prolactin.
So what would be your working diagnosis at the moment in your mind?
My working diagnosis would be early menopause or premature
ovarian failure. Okay, fantastic. So would you both agree, because these patients would come to us as well, to gynecologists as well, so we will think in terms of premature menopause. Okay, so yes sir.
Despite the absence of galactorrhea, as you mentioned, a lady who is on various psychotropic drugs, the possibility of hyperprolactinemia because of drugs and irregular periods or amenorrhea because of drugs should also be entertained.
I didn't get you.
Prolactin, hyperprolactinemia,
yes.
drug-induced,
yes.
causing menstrual
yes.
problems should be entertained because of that history that you provided.
History of psychiatric, I mean, yes, fine, okay. So withdrawal with progesterone, yes, no.
What is that question?
Would you give a withdrawal with progesterone or you wouldn't?
Yes, I would.
Okay, fine. And what do you expect her to have?
So she would not have a withdrawal with progesterone.
She would not? Definitely she would not.
She would not.
Okay, fine. Okay. This exactly was what happened, and she did not have any withdrawal periods. And now, would you want to investigate at the moment? You have waited for 15 days after progesterone, and then she has not withdrawn. Yeah. What would you want to do?
Okay. Like I was saying before, I would want an FSH, LH and a prolactin.
Okay, so you first FSH, LH and then prolactin.
No, the same thing.
All put together.
And I would also, if you can also do, if you have some dilemma, you can also do a pooled sampling, and it has to be fasting. And if you do a pool sampling every 15 minutes, you would get more accurate values.
Okay, so that is the FSH, LH, and thyroids were done and that was normal. And the ultrasound did say that atrophic ovaries and a Doppler ovarian blood flow, which we would want to and say that was very poor. And uterine size was this, and the endometrium was 4 mm, which also says that she doesn't have any much of estrogenic activity. And inhibin B and AMH levels, would you want to do or you wouldn't want to do in this particular lady?
Me? I don't know.
You wouldn't do? You both? Okay, fine. So, Dr. Shubhankar.
Nowadays, we understand...
She's only 32 years old.
Yeah. I mean, we are sort of shifting away from the term premature ovarian failure because that sounds an absolute judgment. We would like to use a term like maybe primary or premature ovarian insufficiency because some of these women may actually resume periods with treatment or without treatment. And one of the ways, I mean, especially when you have an autoimmune basis of premature ovarian insufficiency, you may still have a pool of primordial follicles in the ovaries, though the more developed matured follicles may not be there. And to get an idea of that primordial follicle, possibly AMH, despite the high FSH at this point of time, you could well have AMH level not being too low. And that could be a predictor that this lady could possibly have spontaneous periods, or maybe after treating with GnRH analogs or estrogen progesterone for some time, may have periods again. So in that context, maybe AMH could have a role.
Okay, fine. So that point is well taken. So we would try and think in terms of using AMH level as well. So your diagnosis is very clear that, and though you have the difference of wording and nomenclature, premature ovarian failure. Now, Dr. Mala, would you want to do an ovarian biopsy? Dr. Shubhankar wants to answer that question. Okay.
No, I wouldn't want to have an ovarian biopsy, but if there is a room to do ovarian antibody, I possibly would.
Okay, fine. Dr. Sampath Kumari, would you want to do an ovarian biopsy, or you wouldn't want to do an ovarian biopsy to confirm that it is premature ovarian failure? Okay. So I think all of you have agreed that it's not necessary, as pregnancies have occurred even after an ovarian biopsy had failed to reveal the presence of viable oocytes, and so we wouldn't think in terms of doing an invasive procedure like that. Now, what would you want to do on this particular lady? How do you want to manage her?
Me?
Yeah.
I would put her on EP replacement.
EP replacement straight away. So what E, what P would you put her on?
I would put her on small dose of estradiol and progesterone.
Estradiol and progesterone, okay. So her goals would be reduce the psychological trauma and long-term effects of estrogen deficiency. So lifestyle changes, which we did have, and say 1000 milligrams of calcium and vitamin D, and if I'm wrong, 1000 IU of vitamin D, okay. Regular weight-bearing exercises and reduction of caffeine, smoking and alcohol if possible, and of course we would give her menopausal hormone therapy like ERT, 0.625 milligrams of Premarin, or there are transdermal patches, C2 100 micrograms a day, whichever suits the particular patient, and of course medroxyprogesterone acetate in the last 10 days of her whatever. And vaginal atrophy can be treated by topical E2 cream, DHEA cream. Right? So you would agree with that, or would you want to add on anything or subtract any of them? Would you want to discuss on saying this is better than that? Yeah, Dr. Shubhankar.
Do we have DHEA cream available?
Not available in India.
And
definitely
then the evidence for that, I mean, I'm not sure.
We don't have DHA creams are not available in India. Yeah. Fine. So you would, but topical estrogen creams are available, estrogen tablets are available, so we would put them on that. Okay.
Although DHEA cream is not available, they say that increases the thickness in all 3 layers of the vagina.
Yes.
So it is said to be really very good.
Yes.
For vaginal atrophy, actually.
Perfect. That's exactly the point. I just initiated that. It's not available. If it comes into picture, we will think in terms of using a DHA cream. Quite useful though. And yeah.
I think for a 32-year-old woman, that estrogen, I mean, that dose of CE is inadequate.
Sorry, that dose of CE,
that dose
calcium.
of CE, no, of the conjugated equine estrogen, that's inadequate, I think.
Is adequate.
Is inadequate.
Inadequate.
We are looking at, in a 32-year-old woman, you're looking at, you want a E2 level that's anywhere between 80 and 120 picograms.
Fine.
So a
1.2?
Yeah, at least 1.2. The way to work is to start with 0.625, but titrated it into well-being and other stuff, and if necessary, levels are not really required.
How would you do? You do a serum estradiol?
You can. If you want to, you can.
Do a serum
but certainly 0.625 is a woefully low dose for these people.
Agreed.
The doses that 0.625 are for HRT at premature menopause or this thing, but at 32, this is somebody who needs a higher dose.
Okay, so we would think in terms of 1.2, and so we will agree on that. Is that the panelists want to agree with? Dr. Mala and Dr. Shubhankar, 1.2? Okay, fine. So he has a hesitant yes. Okay, fine. So I'm sure all of you would be aware of the global consensus statement on MHT, and we have 5 more minutes, and we would go on to the case 3, which is quite a case which the first 2 of the panelists, the gynecology people, would answer more than the endocrinology specialists. So Mrs. 40 years old, P2L2, last childbirth 16 years back, no comorbids as in diabetes, hypertension, not sterilized. She comes to you with a history of 2 months of amenorrhea and excessive periods. Her previous periods were regular except for history of one similar episode of 2 months of amenorrhea last year. General physical examination normal. She's little on the BMI, high 27. Speculum examination PV, nothing major. Bulky uterus, and that's exactly what she has. And so what other additional features will you look for, and what do you want to do, Dr. Sampath Kumari? You want to go through that again? Yeah. She's a 40-year-old, and her last childbirth was 16 years back, and she's got 2 children.
I will rule out the pregnancy also.
Fine, perfect.
First.
And so she's not sterilized, so you will do a UPT and say, and she's come with 2 months of amenorrhea now. So would you give her withdrawal?
First we should see whether she is pregnant, then we have to stop with the progesterone, and then we have to go for the investigation.
Fine. So additional features, I think the other colleagues would be interested in seeing. There's no hirsutism, no galactoria, no acanthosis nigricans, no family history of diabetes mellitus, and family history of uterine cancer present in the mother. That is what the history this particular patient had given. Rest of the things were absolutely normal. And now what would you do with her? You would give her pregnancy test, and if it's negative, you would give her withdrawal periods, and she reports after her periods. Now what do you want to do after her withdrawal?
After 2 weeks, I can go for that endometrial pathology.
You want to do an endometrial
do an ultrasound first.
You want to do an ultrasound first. Any difference of opinion between Dr. Mala and Dr. Shubankar? Would you just wait? You want them to manage the case. Okay, fine. So, of course, investigations were done. T4 TSH normal, glucose tolerance test normal, FSH LH normal, fasting insulin-free testosterone, serum prolactin. We did have enough discussion on that. We will keep quiet with that, and we will not go into that. Ultrasound was done, and uterus 10 by 8 by 6 centimeters, ET 7 mm, feature suggestive of adenomyosis, and both ovaries show features of polycystic ovarian syndrome. Now, what would you want to do, both of you? This is the report. So I'm not going to say that I will repeat an ultrasound now. So we did have enough discussion already, and our doctor from Kerala was very apprehensive about doing one more ultrasound. So we will take this feature as the final one. So she's got PCOS now. What do you want to do?
This patient also presents with menorrhagia.
Yes.
I will do endometrial sampling is, although she has an adenomyosis also, endometrial thickness is only 7 mm.
Yes.
But still I will do an endometrial
But I have not still told you whether this ultrasound was done before the periods or after the periods. It definitely varies, and I think we will want a premenstrual endometrial thickness to say whether the thickness was good or bad. So we would do a premenstrual ultrasound, if at least the thickness of the endometrium. I wouldn't say we'll repeat the ultrasound picture. So late PCOS, would you treat? She's had children, she's fine, and would you treat her or would you not treat her at all? Or what do you think are the implications of leaving her alone and say just take progesterones whenever you can?
No, it is mandatory because she can go in for metabolic syndrome, she can go in for endometrial carcinoma.
Her mother has a history of some
so
uterine
because
carcinoma.
of all these things, she needs at least...
Fine. So all these are implications of late onset PCOS. Definitely we would be happy to treat this particular lady with enough respect to the endometrial pathology. So coming to tissue diagnosis, how would you want to do the tissue diagnosis? Yes, madam.
Why did you say premenstrual? Because you want to see the endometrium when it is the thinnest.
Sorry?
You want to see the endometrium after she sheds the endometrium. If the thickness is still high, that's when you would go for an endometrial biopsy. So you don't look...
You wouldn't get anything. That's exactly the point.
Pardon?
You wouldn't get an endometrial sampling if it is after the periods. The endometrium is thick premenstrually.
Yeah, but that is normally thick.
Yeah.
So even if you have 13 or 15 millimeters...
No, the idea of here is we are ruling out an endometrial CA.
For endometrial CA, you have to have a thick endometrium
Yes.
Post-menstrually. Post-menstrually at 5th day, if you have a
But
thick
if you're
endometrium-
embarking on the thickness of the endometrium, I think you'll have to have the 5 and 10 millimeters of endometrial thickness is premenstrually. You can't take it postmenstrually. Yeah. Postmenstrual. Sampling, it is premenstrual.
Yeah, timing maybe, yeah. Of the biopsy can be.
Yeah.
But otherwise you would, for
Do a postmenstrual, day 4, day 5.
endometrium, you don't have to worry.
Yeah, that I agree. Okay. Yeah.
No,
So now
otherwise
how
also even if the endometrium is thin in this patient with menorrhagia, we should know the thing, you will know.
Sampling, yeah.
And the endometrial sampling is mandatory.
We are running short of time, Dr. Shanti. How would you want to take the sample of the endometrium? Sampling, fractional curettage, or would you want to do a hysteroscopy? What would you want to do?
Sampling is
Office
good enough, I
sampling
think.
is enough.
OP procedure.
Yeah.
OP procedure. OP procedure is enough, though the yield is different with Charman, Vabra, whatever. Okay, so endometrial sampling was done premenstrually, which is what Dr. Rekha was hinting at, and the report was disordered proliferative endometrium, no features of malignancy. Now what do you want to do? Am I allowed 2 more minutes? We'll finish this last case, yeah. Yeah, what would you want to do now?
No, this patient, it will be better if she has regular withdrawal bleed, so that is mandatory for this patient.
So you would-
She's anovulatory endometrium.
Yes. So she's anovulatory. So what would you want to give?
Medroxyprogesterone acetate can be given 10 milligram for 10 days.
Okay.
Yeah.
So would you want to think in terms of OCP or would you want to think in terms of only an MPA?
OCPs also can be given, low dose OCPs which will regularize the cycle.
Okay.
That also can be
She
given.
has irregular periods as
So
well.
that also can be given, or else the cell
Would you want to
won't
think in terms of LNG IUS at some point of time?
For adenomyosis also,
Yes.
that will be dual protection. So that will be good both for adenomyosis as well as.
Dr. Sampath Kumari, when would you want to think in terms of hysterectomy for this lady?
No need for hysterectomy.
Sorry?
With that medical treatment, if everything goes wrong, no need for hysterectomy. If pathology report is with complex hyperplasia, like that we can think. Otherwise, no need for
You will first
hysterectomy
try
in this
OCP
patient.
and LNG IUS.
You can go with
Fine. So this here is where we have the drospirenone based OCP where it reduces the weight and etc. So there is enough good cycle control, and I would respect the warning which is given by then, but this is the evidence which we have as of drospirenone cycle control and body weight and overall satisfaction. LNG IUS bar hysterectomy, we have advantages of LNG IUS over hysterectomy in so many other ways as well, and it improves hemoglobin, effective for treatment of fibroids, prevents anemia, alternative to hysterectomy, accepted. It can be used as HRT, and endometrial hyperplasia and stage 1A grade 1 endometrial CA can also be treated by putting a levonorgestrel releasing intrauterine system, and hysterectomy is not probably the only answer. We can think in terms of options of LNG versus hysterectomy depending on how you talk to the patient, how the patient responds back to that.
adenomyosis also, you can use
It can improve.
LNG, adenomyosis.
Adenomyosis also, and this particular patient has adenomyosis, and so it will improve the adenomyosis. So probably it's we could think in terms of any other discussions would you want, or we would end the panel. We've taken 2 more minutes extra. Yes, Dr. Mala and Dr. Shubhankar, you're happy with this discussion? Okay, fine.
Just a question,
so,
sir.
yes, sure.
To the endocrinologist, how safe do you think it is for a 40-year-old to be prescribed on pill for regularization of cycles?
How safe is it for a 40-year-old lady to be prescribed on a pill for this particular patient? We did discuss about OCP. Let's not go into whether it is drospirenone or desogestrel, but how safe is it? They want you to answer.
No, I think it's quite safe. You can give up to 50 years low dose, no problem.
Okay, we need to stop.
Comorbid condition too.
Yeah, okay, fine. So with that, we would end the statement that we would keep women happy whichever the age they are. Where women are honored, their gods are pleased. But where they are not honored, no sacred right yields rewards. When the female relations live in grief, the family soon wholly perishes. But the family where they are not unhappy ever prospers. Thank you very much for your patient listening, and thank you, Dr. Krishna, for this opportunity. And I thank all the 4 panelists who had a very fantastic contribution to make this panel very well. And of course, we had an excellent audience interaction. Thank you very much, and hope I'm not holding you before lunch. Thank you very much.
I thank the Trento endocrinologist for giving us an opportunity to participate in this panel. Thank you.
Thanks, panelists. And can I have another round of applause for this amazing moderator that we have?